practice of managing cancer largely depends on the type of cancer. So talking about general cancer will require us to talk about almost every part of cancer. But be that as it may, we are going to, as much as possible, give a general description and overview that is going to put us on the stage on how to approach every single cell we come across. So my slide is not moving. So to start with, cancer, as the name implies, has different names. It can be described as a cancer, as we all know. It can be plasma, tumor, malignancy, wherever it comes from, and with whatever name it comes to us, it is a disease characterized by uncontrolled growth and spread of abnormal cells. So generally, cancer cells have an uncontrollable. Thank you very much. At least we are getting peace now, because some noise at the background is becoming too much. Okay, so cancer, as I said, is a group of disease characterized by uncontrolled growth of abnormal cells. Ordinarily, every part of the body is made up of cells, and those cells in the body are meant to live a certain period of time. From the time they are produced, they divide to certain limits of time and they die. There's a program they call program cell death. So a single cell has to live to a particular lifespan. So any cell that boycotts the normal process of, that is the normal process of that program cell death, will continue to grow without limits, and the growth will be in a very fast way, in the sense that that is what is called uncontrollable growth cells. And those cells have the ability to also invade cells that are around and even break away to move to others within the body. And because of their ability to form new blood cells wherever they find themselves, that is what is called angiogenesis. And their endless replication potential, because they keep on replicating without stopping. That is why they are even called cancer cells, or they are called tumors, or they are called neoplasms, or they are called malignancies. And therefore, they continue to survive and they continue to invade other cells. And that is the basis for the disease. And when you look at the global incidence and mortality of cancer cells, you realize that cancer is of public health importance. You can see 19.3 million, according to global cancer incidence and mortality, 19.3 million new cases as at 2020, and 19.9 million deaths. So that means something somewhere is wrong. Yeah? At the point of diagnosis, at the point of treatment, or at the point of really managing the cancer itself, something is wrong. So ordinarily, this is of great public importance. Of course, we talk about etiology of cancers. We don't have to come here to talk about etiology of cancer. Everybody is aware of cancer and how cancer comes about. Two major etiologies: environmental factors and genetic factors. The environmental factors are one way or the other related to genetic factors, because in the real sense, what happens to cancer cells that loses potential to control its growth has to do with the DNA component of the cell. That is the genetic component of the cell. So environmental factors, whether occupational, lifestyle, chemicals such as drugs, have the ability to tamper with the genetic composition of the cells in order to change the coding system and make the cell to continue to grow without any control. This uncontrollable growth of cells, to say it, is actually the target of most of the cancer therapies in order to be able to kill specifically those cells that have uncontrollable level of growth. So the cancer cells, their toxicity is targeting those cells that multiply without thought. And along the line, you also try to attack other normal cells, and that is what is responsible most of their toxicity. So generally, talking about etiologies, we don't have to waste our time. Environmental factors such as occupational factors, lifestyle changes, drugs, which is part of chemicals, and of the genetic factors. I told you the environmental factors and the genetic factors together, because the environmental factors can only cause cancer when they are able to tamper with the genetic cause. While in some cases, genetic factors that without any knowledge of how they come about, somebody can just come up with cancer without any reason. So majority of the genetic factors that cause cancer, nobody can explain exactly how it happens. So people that have risk factors and they're exposed or expose themselves to some of the environmental factors are more susceptible to come down with cancers. These are generally 3 of preventing cancer. When these methods are effectively employed, these strategies have the potential to stop cancer occurrence and progression. One of the methods is screening. As the process of screening detects pre-malignant changes. We have different types of cancer, whether it is breast cancer, it is cervical cancer, colorectal cancer, or any kind of cancer. During the screening process, we detect malignant changes. There are special methods in the hospitals and other health centers where people can go and get screened. And that the process of that screen, any part of the body that is susceptible to develop cancer can be screened. And there are standard methods developed in the screening processes to identify malignant changes within the tissues that to predict the occurrence of cancer cells. Early changes on those places can give some impression as to whether breast is likely to come up with cancer, whether cervix is likely to come up with cancer, that esophagus is likely to come up with cancer. During those kind of screening, these are methods that employ standard guidelines in order to screen individuals who are healthy. Because when you talk about prevention, you are talking about people who are healthy. And this is one of the greatest tools that can be employed in order to stop cancer from happening. Because one of the problems of cancer is late diagnosis. Majority of patients that come down with cancer usually get to the hospital at the time when it is too late. And by the time it is too late, even after diagnosis, the treatment of that cancer is usually very, very difficult. That is, if it even become possible at all. So screening process is one of the methods of prevention, and of course, lifestyle modification. The clinical researches have shown that there is a strong association between risk of cancer and lifestyle factors. People that live sedentary lifestyle, people that eat any kind of junk that come across them, people that expose themselves to all sorts of things are more likely to come down with cancer compared to people who watch their weight, people that do not exhibit sedentary lifestyle, people that don't expose themselves, most of the environmental factors. And of course, we have therapy. When you talk about therapy, you are talking about process of using anti-cancer or other chemicals in order to prevent cancer. And usually chemotherapy is usually a result of treatment. For example, a patient might go to the hospital for the purpose of screening for cancer and will be identified to have some or certain chemicals in them that are predictive of cancer. For example, somebody can come down. Hello? Am I on?
Yes, you are on. I can hear you.
Yeah, you are on. Yeah, I can hear you.
Yeah, you are on.
What we're saying, chemotherapy is another method. Even though we know chemotherapy as a set of treatment of cancer, we should know that chemotherapy can be used, for example, use of drugs such as tamoxifen in certain people that have the potential to develop cancer as preventive measure. And we have human papilloma vaccine for especially cervical cancer patients, especially people who have the susceptibility of developing cervical cancer. So this really, even though there is another method which I have not added here, which is surgery. Surgery also be used as a preventive measure. For example, someone going to the hospital with lump, when the lump is identified, when the lump is identified as any sign, when the lump is identified as any sign of cancer on it, usually the physicians or surgeons advocate for the removal of lump at the time before the malignancy even starts. So in most cases, type of surgery in which the lump will be removed from a breast of an individual with the fear of developing cancer, a surgical procedure employed for managing or for the prevention of cancer. So generally, we can say with screening, we have lifestyle modification, we have chemotherapy, we can also have surgery, all as methods that are being used for the prevention of cancer.
Sorry.
The noise at the background.
Can you please hold on? Please, I would like all participants to mute their phones or their system, please, so that the distraction will be lesser. Dr. Richard, please, can you also get across to the IT person to mute everybody from the background? Let them mute everybody generally so that at least we can have lesser distraction. Thank you very much.
Go on.
So we can go on, sir, while they are doing that.
Thank you very much. Having gone through just to define what cancer is and understanding of how tumors develop, we are talking about major determinants cancer. One of the mistakes make pharmacists, not all about cancer, but mostly about all the disease conditions they have. We just feel we are only concerned about drugs. So anything that doesn't have to do with is not our business. So that we don't ourselves management of all disease conditions. And I think one of the disease conditions that calls the attention of pharmacists much more than any other disease is cancer. Because by the time you miss or you think you can use the process of pharmaceutical care or use the process of pharmacotherapy just like an event, that is the way we use it. That at the end of the day, we just have a list of roles that do this, what naturally getting ourselves involved into the management team of all disease conditions. At the end of the day, we will be playing no role. Because ordinarily, there is no way you can understand anything about therapy or management or treatment or anything of a special type of chronic disease conditions or even disease conditions that are not chronic without being general, without being part and parcel of the care team. And being part of parcel of the care team means understanding every stage, right from the time the patient comes into the hospital to the time the patient is prescribed drug. Because prescription generated for any type of patient is a function of the processes the patient goes through, right from the beginning of the process to the end of the process. So if as a pharmacist you do not understand the process in which the diagnosis was a diagnosis comes from, if you do not understand how the severity of the diagnosis is identified, if you do not understand the reason for the choice of particular management process, I assure there is no way you can give any meaningful control, because majority of the processes of diagnosis, especially from the beginning to the end, are the same processes you use at the end of the day in evaluating the efficacy of drugs. last one we are talking about, I call these major determinants of cancer management because they are the major determinants. As long as these four things, the diagnosis, staging, patient performance, and prognostic factors are not determined, there is no way any proper management can be identified for any patient. And if any patient is choosing to go through a particular management process, either using radiotherapy, using chemotherapy, or using any other form of therapy, so that treatment could definitely be faulty. And that is one of the reasons we continuously call on people that claim to have traditional way of managing, especially cancer. Nobody is disputing traditional medicine. Nobody is disputing, but the truth of the matter, a lot of people come down with a lot of claims of managing patients that have come with cancer. The first question to ask the patient is, where was the cancer diagnosed? For example, in this diagnosis, think about obtaining samples, and this obtaining samples from either a lump, a growth, or any other particular area where cancer growth has been suspected. Remember, we said cancer is an uncontrollable growth of cells. So wherever there is cancer, there is likelihood of development of a mass or a particular growth. So in the first instance, after the initial presentation of the patient to the hospital, because majority of patients that come down to the hospital with come down to hospital with cancer cases don't always to hospital with the thinking that they have cancer. They come to the hospital with non-specific symptoms. People come to the hospital with a lot of complaints, weight loss, unexplained anemia, malaise, lethargy, some pain, some kind of ulcer that refused to, and some painless growth in various parts of the body. So when those people come to the hospital, the next thing is, after making some kind of impressions that are not cancer, is coming down with some assessments that are not cancer. Sometimes a patient can go through several months receiving different of treatment, because normally when patient comes to the hospital after through all the process of investigations, the patients are given drugs. The patient goes back home, take the drugs, the symptoms continue. Come back, that is how we continue to have this back and forth. So at the end of the day, certain things happen that either physician or soul will now begin to suspect. That is, if the patient is not lucky, but patient is initially lucky. After coming down with those unspecific symptoms, painless lung, unexplained blows, some kind of unexplained anemia, and the rest, and those symptoms are with certain we send presentations on the patient that show that this patient is likely suffering from something that has to do with cancer, and probably at the beginning of the day, the patient suspects cancer and begins to go into the process of diagnosis. That patient could be likely to have his cancer diagnosed at early stage. What we are saying, whether in traditional or in hospital, in whatever, this is a diagnosis is just a method that it's one thing that no one can avoid. And one of the things is to get different methods of taking samples, and those samples go to chemical pathology for pathological diagnosis. And that is the beginning. And by the time cancer cells are diagnosed, for example, in breast cancer, they use fine needle aspiration. In other places, they take it for biopsy and all other methods where the sample will be taken and sent. And by the time that particular cancer cell is taken from either a painless lump or from some kind of disease that brings about some if those samples come down positive with some cells of cancer as a result of this chemical pathology or histological studies, then the next thing is to identify the extent of cancer, because in most cases, at the time the samples could be taken, that cancer could have been in that individual for some time. So the next is to go into stages. And in this stages, we have two things. There's what we call staging, there's what we call grading. So what we are saying here is use of all the methods. So you can see it is very important for a farm to understand that there is somebody that has been diagnosed with based on biopsy, based on pathological diagnosis. Now the next thing is grading and staging. And that staging use of CT scan, MRI, PET. In fact, PET scan, I think the last one in the 2 years, I know we don't use PET scan in Nigeria. Recently, I think there's only one center conducting PET scan in Lagos, and I think the price for a single PET scan is 500,000. And in most cases, this PET scan only usually for patients that CT scan and MRI and other investigations are not able to identify metastasis of cancer. So you can see what I'm saying in essence is that all these methods are going to be employed in order to identify what we call tumor mass. For example, if it is a breast cancer or cervical cancer or colorectal cancer or nasopharyngeal cancer. So every cancer has what is specific tumor mass. Those, for example, prostate-specific antigen is a mass for prostate cancer. So when you have a prostate cancer, one of the initial at the preliminary stage you identify as a marker is prostate specific. Of course, there are other things you have to identify for you to get to the level of definitive diagnosis and staging. So what we are saying here is that you can see one of those they use is TNM, where T is tumor, N is node, and M is metastasis. So this tumor TNM is used in order to identify whether the stages, for example, T has values between 0 and 4. That means what is the stage? It's not about the size of the cancer. While N is between 0 and 3. That is to show the extent of node, that is lymph node involvement. So by the time you see numbers on N, it's telling you that already node lymph have been involved, and the M is just either 0 or 1, meaning whether it has traveled away from the original base to other place or it has not traveled to original base. So this will now begin to say, okay, this count is at 1, or it is at stage 2, or it's at stage 0. So the moment you are able to diagnose and you are able to effectively stage cancer, this is where the problem is. Majority of patients that come to the hospital with cancer, just like I said earlier, they come to the hospital after going through a lot of processes, after the denial of not being able to admit that they have cancer, or after going in the hands of fake traditional concoctors, people that tend to have, of course, there are people that have traditional medicine, but a lot of people are using it for money, and they tend to continue to bastardize the cancer patient. A lot of us, when you come to, especially in hospitals, you realize that majority of the patients that have been diagnosed with cancer in teaching hospitals have already gotten to advanced stage. So now we have diagnosis. It has now been staged. The next thing for you to be able to choose particular process or particular management strategy must identify patient performance status. Here you are talking about the functional ability of the patient at the time of diagnosis and stages. A patient that comes down with just 1 or 0, who doesn't have any symptoms, who is normally going about life normally. Because you can see, I've told you, there are several scales, internationally recognized scales. The one I've given you an example here, WHO performance scale, which has numbers from 1 to 4, meaning from good works. By the time you use that, that will tell you the performance status of that patient. And that is going to inform you on the kind of treatment you choose for that patient. Somebody who is at age 4, there are certain treatments, by the time you choose those combination treatments, considering the toxicities of almost all the treatments in that patient, you might end up in the patient out to his early grave. Not even the disease itself, but the treatment, because we know how those treatments are. So now, and of course, you have to talk about the prognostic factors. The prognostic factors are very important also in determining the type of treatment you choose for patients. Sometimes these prognostic factors can be used together with the opinion of the patient to choose. For example, a patient coming down with brain tumor that has already metastasized. The truth of the matter is, majority of patients with brain tumor that has metastasized, probably stage 4, one way or the other, even though we don't, now, the issue about prognosis here comes into play. A patient with malignant agree to pay millions of naira for him to have surgery. And when surgery is conducted, before the surgery is conducted, the patient could be told that the surgery is only going at 2 to 3 months to his lifespan. It's a choice. If that surgery is combined with radiotherapy, and is combined with chemotherapy, the patient might even have his lifespan shortened because of the necessities of this. So now, the prognosis will now the patient to choose. Are you going to go for only chemotherapy? You are going to go only for radiotherapy. Are you going for the combination? Depending on what literature and experience of the patients have said, probably that combination is going to do patient. So the patient will now choose. This is prognosis, because if this thing is done, this patient might get additional 3 or 4. If this thing is not done, this patient may likely die in the next. This is a bad prognosis. But in a situation where there's good prognosis, for example, if the cancer is identified at stage 0 or stage 1, where it is there at a particular area, it can easily be removed from there, and the patient is generally doing well. The functional status of the patient is okay. Then you now choose as much as possible the best combination, no matter how terrible, considering the state of the patient. And when the management starts, you now begin to monitor how the patient is responding, because it is one thing to start the management. It is also another thing to monitor the progress of the management, because you have markers. Just like I told you, these are diagnostic markers at the diagnosis stage, but I assure you, these are also completely used to monitor the effectiveness of therapy. So thinking as a pharmacist you don't have business with diagnosis, then it's a distortion. So anybody who will want to practice oncology must understand the process of diagnosis, must understand the process of staging, must understand the process of performance, identifying how patient is faring, and the prognosis of every single cancer. And one thing that makes cancer very, very difficult to handle is that most of the cancers have different prognosticators. They have different markers. They have different predictions. For example, you might have a cancer, for example, breast cancer that is located at a particular local area. When it is removed, there is something we call micrometastasis. This micrometastasis, even going through MRI, CT scan, PET scan, and every other method, it will not show that the cancer has traveled to anywhere. But the micrometastasis has already been transmitted to other areas, but not. That is the reason you will see combination therapy with surgery, chemotherapy. Because surgery is a local treatment. Radiotherapy is a local treatment. You cannot give radiotherapy to the entire body. You don't do surgery to the entire body. So going into systemic therapy, which chemotherapy, that is use of drugs, is one of them. It's an option. When the cancer is removed, to convince anything to go for chemotherapy after surgery is another problem, because at the time you will be telling a patient whose breast has been removed as a result of malignancy, go for systemic therapy despite all the toxicities of that medication. It's very difficult to get confused, because at the time after the removal of the patient is having no symptoms. The patient is feeling nothing after the wound has healed. So the patient it is very difficult to convince patient to go. So what we are saying in essence here is that these are the major determinants: the diagnosis, the stage of the cancer, the patient status in terms of functional ability, and the prognosis. This will be put together in order to identify what kind of treatment. You can see a simple example of prognosis here. In the first column, you can see good performance status, no penetration of the tumor through the bowel, absence of nodal involvement, and absence of deep metastasis. This is favorable. But in the second column, presence of nodal involvement, presence of deep metastasis, bowel obstruction. This is just in rectal cancer. So by the time you see the first column or the second column, you can see decision about these two different situations will definitely be different in terms of choosing which management strategy should be employed. So what are the modalities in the management? After the diagnosis, the staging, identifying the status of the patient, and also looking at the prognosis, prognostic factors. Now, how do you go about the treatment? Majorly, you have to define the goal. Depending on those factors I have mentioned earlier, you now have to look at it. For example, if it is a localized cancer, after the staging, it has not involved any node, it not traveled to anywhere. The goal is usually cure. But in another case, if it has traveled, if the significant nodal involvement, and depending on the quantum of the nodal involvement, it could either be providing palliative care to the patient with relief of symptoms such as pain and maintaining quality of life while waiting for the patient to go, and probably trying to see how you can prolong the patient's life based on literatures and data. That is what I just finished telling you, for example, in case of an advanced breast tumor, where a patient has a malignant tumor. In the case of malignant tumor, for example, if you go for surgery, for example, in malignant tumor, when you open the brain, that cancer has traveled to a lot of areas in the brain. Even that common sense should tell you that if the brain is open with the intention of resecting or removing the cancer, there's no way you can remove all the cancers. What they do during the surgery is to reduce the amount of the cancer certain stages. And there are areas where nobody can even touch to remove cancer cells. So what they do is just to reduce by scratching, they call it scratching, or by scratching some parts of the cancer and leaving the rest. So there's no cure for that, and there is nothing anybody do. So what they will do is just to use surgery as one of the options, and probably chemotherapy and radiation, or radiation alone. But the essence of the care treatment is either to give the patient relief from the enormous pain the patient is going. Of course, after the treatment, after the surgery and the chemotherapy and the radiation, as the case may be, the patient is likely going to have some relief of the pain. The patient is likely going to have some little improvement in quality of life. So in that instance, definition of why this particular treatment should be chosen or why this should not be chosen is largely, you can see, dependent on those determinants I have just mentioned: the diagnosis, staging, the prognosis, and the patient status. I am just giving you one example, and this is the same almost every cancer. That is why by the time there is cancer and the patient refuses to go to get the appropriate action until when there is nodal involvement, there is metastasis right from the beginning, then automatically that patient will have issues. And these are the goals. So now, once the goal is established, is it cure? Are we going to provide palliative care? As I assure you, majority of the patients you come across in teaching hospitals are only, most of their goals are these two: providing palliative care and prolonging survival. And it will surprise you to know that even at the prolonging survival, the time of the prolongation is not much. Majority of the patients, because people refuse to come to hospital. People believe some superstitious beliefs. People really believe a lot of things about cancer until when the cancer begins to develop beyond the limit of certain things, then they now begin to rush to hospital. And by the time they get to hospital, it is too late. And there's no way anybody can chase you away from the hospital. Whatever level you come, all they can do is, but it is painful in most cases to see someone lying down under intense pain and at the same time spending huge sums of money procuring chemotherapeutic agents, going for radiotherapy and other treatments, but right inside you, all the prognostic factors, after checking all the prognostic factors, you know this patient was going to die. And there's nothing anybody can do. And I assure you, the patient must die. And that is what, as of today, I've not seen any patient at that level that has survived. People claim patients have come to them and they have given them medication and they have survived. When you ask them for a diagnosis of the cancer, they always begin to tell you stories because majority of those do not have basis. Majority of those patients have claimed to have survived those kind of things were not originally suffering from cancer. In fact, I've seen someone trying to manage ordinary leishmaniasis, visceral leishmaniasis, and he was calling visceral that cancer just because he doesn't have the technicalities and other things. Of course, that is why currently we have those traditional setters. Traditional bone setters are trying to key in the orthodox medicine. What they do now is when you bring somebody with broken arm, they always send for X-ray. They look at the X-ray and from there they try to see how they can set the bone back and do the normal they used to do. And of course, after 2-3 days, also ask the patient to go back. So at least if we can go into our own people that claim to have traditional medicine, at the end of the day, we will be able to identify those traditional practices that are genuine, those traditional practices that are not genuine. Because it is not enough to have herbal concoction. Just because you have used in vitro or in vivo experiment animal models and you realize that the size of the tumor you have developed on rat or on mice is reducing. Of course, it will reduce. But the issue about cancer is after killing that particular cancer, how long does it take to reoccur? How long does it take to come back? And as you are trying to manage this thing, where has it traveled? If you don't have all this information and you give even that particular area where the cancer is has been completely destroyed or has been removed, at the end of the day, that patient is going to have another cancer one way or the other. And probably by the time he has the second time he was going to have cancer, it might not manifest until at the late stage. And that is what is responsible for most of the fatalities in cancer management. So look at the treatment methods. We have 2 categories of treatment. You can 4 options, 2 categories. The first category is surgery and radiotherapy, while the second category is specific therapy. Common sense should tell you that when you use surgery, you are using surgical removal of a local removal of breast, removal of cervix, removal of a polyp or a particular part of the colon where polyp that has been identified to have developed into cancer is. This is local. When you use radiotherapy, those of us who have the opportunity to witness how radiotherapy is know that the way and manner it is localized is second to none, because the way the patient is going to be packaged to even see they have protected other cells, even within the immediate neighborhood, to get the radiation. It's definitely telling you radiotherapy is also a local therapy. So now, why do we have this type of treatment? What we have here is to tell that cancer therapy, based on those determinants we have seen, the diagnosis and everything, you now come here and targeted and biological therapies, especially in Nigeria, is still evolving. That is why our major focus is chemotherapy, radiotherapy, and surgery. And focus for today in oncology pharmacy practice is generally chemotherapy. But the fact that you hardly see any cancer patient, especially cancer that have started going developed without undergoing any of these 3: surgery, radiotherapy, and chemotherapy. It is either surgery and chemotherapy, surgery, radiotherapy, radiotherapy and surgery, chemotherapy, radiotherapy, surgery. That is how it's by one way or the other. And you can now imagine radiotherapy is as toxic as chemotherapy. What makes chemotherapy much more troublesome is that it is a systemic treatment. When you administer either by oral or by intravenous infusion, any anti-cancer, you are now administering the anti-cancer to the entire system. But radiotherapy is local, surgery is local. So assuming a patient with colorectal cancer that's been identified in a localized environment, the first thing to do is to remove the mass. That is surgery. So now, with the knowledge of that, even if the the scans, MRI, PET scans, and other investigations have revealed that there is no distant metastasis, I want to remind us that there is this thing we call micrometastasis. That is why majority of cancer patients that have gone through surgery, and in combination of surgery, radiotherapy, and chemotherapy, tend to have the cancer coming back after less than 5 years. When you go and check records, for those who have been in research in oncology, will gladly tell you this is just the truth. People have come and have had their cancers removed by surgery, have gone through radiation, have gone through chemotherapy, but the cancers come back. The reason why the cancers come back, even though at the time of diagnosis, there was no evidence of nodal involvement, there was no evidence of distant metastasis, but the cancers come back. So that is the reason, even after all the stages, the cancer seems to be at first stage or even 0 stage, 1 stage, which are largely cured. They need either radiotherapy and or chemotherapy combination. So this decision to combine or not combine is a function of those factors I have told you. One of the main factors is that performance status of them. We use any scale to know, because you know the body chemotherapy is going to put a patient. So by the time you have a patient that is already exhausted, that is already dead, and you decide to choose chemotherapy for that patient, and any type of chemotherapy, any type of combination, you might end up sending the patient to errors. So these are the decisions. So what we are saying in essence, when you talk about a patient diagnosed with a local tumor that has gone to advanced stage, nodal involvement, and distant metastasis, that patient, there's no two ways about it. You have to combine the surgery, you have to combine the surgery with radiotherapy and probably with chemotherapy, because that patient will need, because that probably alone is telling it's an indication for use of drugs, because surgery can only remove the original cancer that has given the other areas. Radiotherapy is still local. So after making sure that that particular nutritional base has been completely killed, then you have to use chemotherapy to be able to reduce the intensity of the cancer that has traveled to all those areas, and the prognosis of that particular kind of patient is very, very poor. And usually the end of this treatment is either palliative or prolongation of, but cure is not here. The cure is in a patient where the tumor is localized. There is no evidence of nodal movement, there is no evidence of distant metastasis. By the time that is removed, the only reason why chemotherapy is usually indicated is because those tools, either MRI scan, PET scan, or any other scan, doesn't have the ability to identify metastasis. So in order to be on the safe side, after removal, that patient must undergo chemotherapy And in most cases, the patient still undergoes radiotherapy within the local area where the surgery is removed, because you cannot decide, even after removal of the surgery, that those particular around do not still hold micro, that all those things cannot identify. So ordinarily, these are the methods: surgery, radiotherapy, and chemotherapy. Now, these are the methods. When you come to chemotherapy, now our main discussion, having understood how to diagnose, how to stage, how to choose therapy, one way or the other, almost every patient goes through cytotoxic chemotherapy. So you can see what you're saying here. Systemic therapies used to treat cancers. Those they use to treat cancers that are potentially the agents themselves, that is the drug themselves, they are potentially carcinogenic, they are potentially teratogenic, and they are potentially mutagenic. This statement alone tells you a lot. Apart from, by saying they are carcinogenic and mutagenic, they are now saying that the cytotoxic itself can cause cancer while you are treating cancer. So choice of medication is basically risk-benefit ratio. You have to look at the risk of leaving the patient with that disease, and you look at the risk of giving the patient those medications. You have to weigh. The truth of that, in most cases, patients that are born with cancer, you cannot even begin to think, because the chemotherapy agents can also cause cancer. Let me leave it. There's no way about it. You have to choose. So you must choose therapy. You must choose those agents, bearing in mind that those agents have the ability to cause cancer, but their ability to cause cancer is not as deadly as the cancer you are seeing. So they can easily cure the cancer despite that ability. So handling and administering this poses a significant risk to patients and healthcare workers. Therefore, appropriate policies and procedures must be in place to maximize safety and minimize risk while following standard guidelines. Here in Nigeria, we always like guidelines. We always use international guidelines and other things, and some other institutional guidelines in order to manage our patients. And believe me, a lot of us that work, especially a lot of us that work in cancer centers and places where cancer are being used, we don't even care to conduct simple researches of drug utilization, to know type of prescription that are being generated by the physicians within that institution, in order to know the pattern of even the disease. We know it is anti-metabolite, it is alkali agent, we know there are heavy metals, is it platinum based, non-platinum based, we all know about that. But that is theory. We're talking about practical. In practical terms, what are the kind of drugs? What is the pattern of prescription in that area, in that zone where you work? When you look at the pattern of prescription and the pattern of the drugs, the physician, then you now compare it with whatever guidelines. If there is a local guideline, you compare. If there is no local guidelines, national and international guidelines are available. When you compare from there, you can now begin to see the rationalization. What they're doing is rational or not rational. In most cases, you realize it's usually rational. So when you're able to rationalize the drugs, then the next thing is to compare the outcomes. For the past year, you have been using this particular pattern, because in every guideline you have first line, second line, different combinations. So why are we so sticking to a particular guideline? Is this guideline bringing results? How do we assess whether this guideline in the last 10 years been able to produce the required management standards to our patients in terms of clinical symptoms, in terms of economic benefits, in terms of patient satisfaction, in terms of all those indices that can be used in order to measure effectiveness of drugs? Because these are majorly the indices we use in measuring the effectiveness, regardless of the kind of cancer we are talking about. Every cancer has certain markers, but there are general symptoms. For example, you have a cervical cancer. A cervical cancer patient usually comes with vaginal bleeding, vaginal discharge, vaginal pain. We are talking about progression-free survival. That is usually a research time, but that is how you measure them. We have over survival. In the last 10 years, how many cervical cancer patients have been treated? How many of them survived? By the time you have the value of how many of them survived, you now compare it to another standard to see, is this view of survival and death giving any good information about the drugs we are using or about the management strategy we are using? That is where the problem is. That is why you can see these three things. That is where the work of the pharmacist is enormous. When you look at chemotherapy regimen alone, here we are talking about which combination. In most cases, you hardly see a single agent. Of course, every single agent is effective, but in most cases and in most of the guidelines, you hardly see single agent use. That's where the regimen is. Are we using platinum base or we are not using platinum base? Is cisplatin, fluorouracil, paclitaxel? No, it's doxorubicin, cyclophosphamide, and paclitaxel? No, it is cisplatin, fluorouracil, and carboplatin. Depending, that is combination. And why do I have to combine this? Which guideline are you following? Has this one been producing results? What is the comparison between this northwest and southwest in terms of the kind? Oh, I can see this particular region are using this type of combination, and another region is using of combination. When you put the two together, try to look at the mortality index on the two. From there, you now begin to see what is the benefits, which one is the best. Oh, this particular unit, they always combine radiation with chemotherapy. Oh, they combine surgery, radiation, and chemotherapy. Oh, no, they combine radiation with surgery alone. Oh, they combine surgery. Then you can conduct a research to see which of the combination in the last 10 years or in the last 1 year even or 2 years produces the best results. So just we are talking about number, because the entirety of the toxicity of chemotherapeutic agents usually starts from the number of drugs. By the time you know this is the pattern, you know the literatures, I know probably the theoretical toxicities, and I can see real toxicity. Now we go to the second one, which is chemotherapy scheduling. You will be surprised to see that patients that come for chemotherapy are usually administered chemotherapy once after every 3 weeks or 4 weeks or even more than 4 weeks. That is the scheduling. What is the mechanism of action? Remember, when you administer chemotherapeutic agents, they are toxic to cancer cells. The breast cancer cells that have developed carcinoma, the chemotherapy administered to them is toxic to that. But the truth of the matter, one of the challenges of chemotherapeutic agents is that they are not only toxic to the cancer cells, they begin to affect other cells. What do? They kill the cells. But because of the ability of cancer cells to grow faster, they experience the harshness of those chemotherapeutic agents more than the normal cells. Therefore, it kills the cancer cells faster, but at the same time, it kills other cells. One of the cells that gets the impact, the negative impact, is those cells that grow fast, such as bone marrow. That is why immediately you start administering chemotherapeutic agent, you begin to see what you call myelosuppression. That means the bone marrow is depressed because the cells of the bone marrow are being destroyed. And if the cells of the bone marrow are being destroyed, that means you're going to have problem with the white blood cells, with the red blood cells, all those symptoms that blood related will not be to see. So that is the reason why in scheduling, you administer the idea behind the 2 weeks or 4 weeks, depending on the agent, because there are agents that you cannot even give after 2 weeks. The idea is to allow the normal cells that are cancer cells to regenerate and come back to normal before administer the next dose. And in most cases, by the start administering, you begin to see that the patient would start winning because of the toxic effect, the chemotherapeutic, the toxicity of the chemotherapeutic will start to manifest, the hematological problems, the nails, the alopecia, and the rest of all those symptoms will begin to appear. No, the next thing, the patient will come after weeks. That is the scheduling. Before you go for the next scheduling, you have to be very careful to know that administering after 3 weeks is fit for that. When those normal cells have not restored their normal life and you administer, automatically you are killing the cells. And on the other side again, if you allow cancer cells to regain their ability to continue to multiply before the next dose, you might also be doing irrelevant or ineffective. So the idea behind the scheduling is that you give a time after the first dose. I think there is a noise at the background. Somebody should please somebody should mute all the participants so that we can have some peace.
Please, all participants, kindly unmute mute yourself, please. Your children are disturbing us. We know that you are at home, please. Thank you.
Okay, so we are talking about chemotherapy scheduling. After choosing the regimen, now we are scheduling the regimen. You can see the idea behind the scheduling. Today, the dose, most of the cancer patients come to get their treatment and go back home until after 3-4 weeks they come, depending on the kind of toxicity they get. Some of them, because of toxicity, they are confined to the hospital. After you finish managing the nausea and vomiting, all that terrible toxic effects of patients. Then, so what I was trying to explain is that the idea behind the several weeks is to give the normal cells enough time to regain their viability without giving the same chance to the cancer cells. Because when the time is too long of allow the cancer cells to regain viability, you might continue to administer the cells because it's usually between 4 to 6 cycles. That's the cycles of chemotherapy in most cases, and depending on the kind of agent you are using. So within those 6 cycles, every 3 weeks or every 4 weeks or every time you're coming back is based on, but majority of the drugs we use, especially whether the platinum base or the non-platinum base or platinum base, they are usually within the 6 cycles. But what we don't normally do, we do not assess the patient every time, because ordinarily there are cases when a patient comes back after 3 weeks, that patient is supposed to go through other laboratory investigations before administer, especially those laboratory investigations that do with blood. And if at the end of the day you realize that there are some drugs that have renal problems, there are drugs that have hepatotoxicity, you have to make sure that that patient goes for EUCR, probably creatinine clearance, that patient goes for liver function test, understand the level of rise of those liver enzymes, understand the level of deterioration of the kidney function. If not, at the process of managing patients for chemotherapy, you might have a patient that you need to donate another kidney, or you might kill the liver. And this is where the pharmacists are very instrumental. You must be able to understand. And when you go to the next dose, you realize that it becomes a little bit more complex, because here we are talking about chemotherapy dosing. Now the regimen, the choice of agents, the scheduling, how many weeks, and for how many week cycles. And now we're talking about dosing of individual drugs. Mostly because of the toxics, you don't assume doses in chemotherapy. Chemotherapeutic agents are administered strictly on the basis of body surface area. And in the event of any changes in the body surface area, any administration beyond you expect additional toxicity. And that's the danger here. Patient coming down for a particular chemotherapy here, the patient is weighing 70 kg. Because ordinarily in dosing using body surface area, you have to use the weight, you have to use the height, and you calculate that based on meter per meter square. That is the normal process of managing, calculating dosing using body surface area. We have different methods. Every pharmacist should be able to know how to calculate dosage using body surface area. So what I'm saying in essence is that a patient could have hospital after 3 weeks, the patient could have died because of the toxic effects. So the next thing the patient comes to the hospital, that is what we don't normally do. We don't take weight of the patient again. Use the weight of the patient time of admission to calculate the next dose in the next cycle. And care is not taken. That patient will continue to take the same dose until the end of the 6th cycle, even though the patient is wasted losing weight. Means that there is likelihood that the patient will continue to have additional toxic impact, because the patient might likely be collecting overdoses because of the wasting the patient is going through. So you can imagine these are the issues. So now, even from here, you can see whether this chemotherapy is combined with radiotherapy, or is combined with surgery, or it is combined with surgery and radiotherapy. The principal reason you have chemotherapy is defined in the goal. At the end of this chemotherapy, the choice of regimen is done, scheduling is well, chemotherapy is done well, everything is good. How do you assess? One, you assess those symptoms. Patient that comes down, for example, the clinical symptoms, I gave you examples in cervical cancer patient coming with vaginal bleeding, coming down with vaginal discharge, coming down with pain. These are clinical symptoms, and these are things you can physically assess while management is ongoing, or while management is coming to an end. Then the next, how do you assess again? After looking at physical appearance, looking at those of the complaints, they are resolved. Now you come back and do the process of diagnosis. You need to cut. That biopsy needs to be done again to see whether those cancer cells are still there. You can see now, we are going back to that of determining determinants of chemotherapy. After the chemotherapy, where are we going back? We are going back to see how effective are drugs. Because you have to do the staging, you have to do the diagnosis, you have to look at the performance status of the patient. You also have to look at the prognosis. Ordinarily, all the ones you have done at the beginning will serve as what we call baseline. They are already there in the record. Now, by the time you finish, you now come up them side by side. Ordinarily, in the stage, in the appearance of the carcinogenic cell, you should be able to see no carcinoma cells. In the staging, if it was at metastatic stage, it should not be seen, or the level of the nodal involvement and metastatic is so high, it's at 3 or 4, it's able to come down to 1 or 2. That is not cure. It is just to give some peace to the patient, and for the patient to have some improved quality of life, and for the patient to have prolonged survival. That's why you can see we calculate those things in form of quality of life, quality adjusted life, quality adjusted years. All these things are calculated to know how chemotherapy works. Ordinarily, you cannot, there is no way you can just single out a drug and say this is the impact of the drug. No, you say this is the impact of the treatment. Of course, when you go to do studies, especially during research, you can segregate in some cases to be able to know that this is the contribution of the drug, this is the contribution of radiotherapy, and this is the contribution, but this is in the research language. But generally in clinical practice, we know it is the contribution of everybody that translates to the final outcome. So that final outcome is what we're going to see. At the end of this regimen, at the end of the treatment, we look at all the indicators, the diagnostic parameters, the staging parameters, the status of the patient, because when the patient comes, the status of WHO rating was 3. Now, after the treatment, the status is 0, status is 1. That's improvement. That is if 0 to 4 is means from best, from worst to best, according to how it is, or whatever kind of scale we are using. So this is the issue, and we must understand this very, very well before we get to chemotherapy administration. So now, this is the different ways we did chemotherapy. That chemotherapy I'm giving you in block. You are giving chemotherapy, but why are you giving it? Are you giving chemotherapy as adjuvant therapy, or you are giving it as neoadjuvant or synchronous chemoradiation? That is what we call combined modality therapy. In adjuvant, usually given after surgery or radiotherapy, that is the name. When there is removal of the mass, and O, there is radiation. At the end of the day, you now come and administer chemotherapy. This is called adjuvant therapy, and that is what I told you. Probably when there is mass, the first thing to do is remove it. For example, people that come down with cervical cancer, usually once they detect cervical cancer within the cervix, what they do is total removal of the cervix. That's what they call hysterectomy. That is the beginning. So now, at the time in the decision, there are two things. It is possible the decision will be made based on the cancer type that we are going to remove this thing, we are going to remove this mass, whether in the cervix, whether in the breast, in the colon, or in the lungs, or in any body, and now follow with chemotherapy to be able to remove any traces of micrometastasis. That is those things that all the laboratory investigations and scans cannot see. That's one of the reasons. Or for us to be able to remove this breast, because it's already been, it is a very big mass, the tendency to be able to remove with success without leaving any traces of cancer cells is very low because of where it has grown. Then we are going to start with chemotherapy. That is what we call neoadjuvant. The reason we start with chemotherapy today is because we want the size of the tumor to go down so that it can give the surgeons the wherewithal to be able to effectively remove it after removal. And in some cases, even now removal, then you now go for radiation because chemotherapy already been given. And remember, the essence of chemotherapy usually is for systemic micrometastasis, especially in cancers that are localized. But in cancers that have gone distant place, chemotherapy is to go to those distant places and even other places those sophisticated equipment cannot see. Therefore, if the reason for giving before surgery is to bring down the eyes is neoadjuvant, if the reason is after the surgery in order to remove all the detectable and even undetectable disease in order to avoid relapse or recurrence, then it is adjuvant therapy. And we have this synchronous chemoradiation where this is a very terrible situation where you combine radiation and chemotherapy. For example, if you have colon cancer, and the decision based on all the analysis is to combine chemoradiation, you can imagine the GIT impact, the mucositis, the nausea and vomiting. You have double irritation. The radiation itself is irritating the GIT, and the chemotherapy will be irritating the GIT. Combined effect of that irritation will make the GIT side effect so enormous. So this is what they call radiosensitizer. Not in all cases that they employ this thing in the management of cancer patients, but some of them they employ, and the chemotherapeutic agents. The first antineoplastic drugs affect DNA synthesis. All rapidly proliferating cells are more sensitive to the toxic effects of chemotherapy. Normal tissues such as the bone marrow, the spinal mucosa, hair follicles and such tissue sites where drug effects mostly manifested are usually affected. You can see this myelosuppression, the neutropenia and thrombocytopenia are all part of the myelosuppression. You can see the nausea and vomiting, mucositis, they are part of GIT. Anorexia is also part of GIT. When you talk about alopecia, it's talking about the dermatological effect. We have cardiotoxicity, we have nephrotoxicity, we have pulmonary toxicity, we have infertility, and more importantly, we have secondary malignancy. At the process of managing patients with cancer, that patient can develop another cancer, especially sarcomas. So generally, I decided to just pick some of them too in a slide because I assure you, if we are going to talk about the adverse effects and management of adverse effects of anti-cancer agents, that alone, in the next 2 hours, we cannot finish. So, but we must understand the idea behind for example, this myelosuppression. When we know those cancers target dividing cells, And by the time they go into the body, they begin to kill those dividing cells. The bone marrow that does not have cancer will be affected. Therefore, those blood, definitely, because the bone marrow produces the blood. So by the time it has been suppressed from carrying out its normal function, you begin to see those symptoms. Nausea and vomiting within the kidney. So understanding where the toxicity is coming from and the risk for the toxicity is almost the first stage in managing toxicity. Because in a lot of cases, these toxicities are managed by, sometimes they can be managed by adjusting the drug. Sometimes they can be managed by delaying the cycle, like I told you in the chemotherapy scheduling. Because of toxicity, sometimes you can decide to increase the length of the cycle. Because of the toxicity, can modify the doses. Because of the toxicity, you can use alternative drugs as different options. Toxicity alone, because especially when you talk about cardiotoxicity, you talk about nephrotoxicity, and you talk about pulmonary toxicity. These are toxicities that can send patients to the grave immediately. So you cannot play with those toxicities. But there are toxicities you just have. They are strictly associated with the use of the chemotherapy, and they don't have any special way to manage them. What they are, especially those toxicities that have to dermatological, like alopecia. There's nothing you can do to alopecia, and it is not usually distressing. By the time the chemotherapy comes to an end, all the dermatological problems will begin to reverse. Some of the toxicities are like this, but toxicities that can affect the health and life of individuals are, and managing the toxicities is also a topic on itself. And what I tried is to look at generally how to be able to reduce those toxicities, and also to be able to increase the effectiveness and the outcomes of the management of those patients by something like prescription verification. When you talk about prescription verification, you can see a pharmacist in oncology doing prescription verification. I assure you, in the kind of settings we have, if you are going to employ the principle of prescription verification alone, you're going to be fighting a lot of consultants. You for the regimen, whether the regime chosen for the patient is right, according to standards, according to the patient's status, according to diagnosis. That is the reason why to understand that process of diagnosis, state, patient status, and everyone there is a guideline. Those guidelines are also dependent on the patient. So you have to understand the condition of the patient to be able. So when you look at it, you check the regimen, and that regimen you can only say this regimen is right or wrong when you have all information. So assuming a pharmacist doesn't know how to look at MRI results or results, you don't have to look at MRI results and interpret it, but you should be able to look at the results and understand. You cannot look at and understand. You cannot look at biopsy reading, understand. You cannot. When you cannot understand this, I wonder the kind of intervention you have. Because in a situation where you need to look at the regimen, you must be able to put it side by side with those objective parameters for you to be able to see whether the regimen is okay. Not a situation where you have to challenge anybody, but it's a question of evidence. Mr. a physician managing this, and of course, you are not the one to make the decision. But I have no reason to believe that this patient, this, and this. The patient status is so far according to WHO scale that, or probably you might have seen that the patient status has not been. So please, Mr. Physician, why are you choosing this thing though the patient status has not been assessed? You know, the burden of toxicity on this, especially this particular dose, is so enormous that the patient status is not up with so. This is just a simple body that doesn't have anything to tell you will comply, or will tell you will come down with another superior argument. The question of educating each other. So you're talking about checking prescription. Did you check the prescription? There is no interaction. Those interactions can increase the concentration or decrease the concentration, or impacting the metabolism or the metabolism. Of course, we know the implications of metabolism or increasing metabolism. These things can go in that. Are you talking about in the timing of administration? This guy was in the last 3 weeks, and this prescription is okay. How many days? The last prescription was in 15 days, and ordinarily there should be at least 3 weeks interval. Another one is administered, because the intention of administering drug by shortening the time is that you are giving additional dose to the normal cells before they recover. So it means you're killing more and more normal cells rather than killing the normal. Of course, you can. The only thing is to be the only thing that can happen when there is enormous toxicity, you can extend the time, but in most cases, shortening the time is not an option. So checking the time of administration, checking the demographics. Of the demographics of the patient is to check the weight. Is this commensurate with the dose? Oh, this is the weight that has been taken from when the patient was admitted, almost 6 weeks ago, and the patient has been wasted. The patient has lost almost 5 pounds. When you go and do the body surface area calculation and calculate the dose, you realize that the patient might be given an overdose. Probably at the time you are doing that, the patient was giving same dose the other time, and the patient is coming down with an increased adverse reaction because the dose is almost killing the patient. So this is check body surface area, check dose calculation, check the method of these are verification. And what do you do in cumulative dosing? Drugs that have cumulative, like doxorubicin. There is a particular way to calculate cumulative dosing in order for that particular drug not affect the heart. So by the time the patient begins to collect, to get administered those drugs, not begin to calculate the cumulative based on parameters, because there's a way to do it, and there are parameters, and there is a range of doses that patient must not exceed based on the weight and body surface area of patient. So this cumulative dose in certain drugs that can affect certain vital organs is very, very important. And this dose modification or delay. Are we going to delay this? We are going to modify this dose based on the outcomes. And those outcomes are the same. You are sending for ECV. You are sending for full blood count. You are just to see how the neutrophils are faring, how the thrombus plates are faring, because your bone marrow is being suppressed. And when you continue to suppress it beyond certain limit, today patient is coming back, but the CV is showing 15%, and you need to administer additional drug that has myelosuppressive effect, then definitely you have twice. This is what you call drug interactions, patient interaction, and counseling. These are all very, very important in managing patients in chemotherapy, and this is majorly the role of pharmacists. And what I want to emphasize here is that I continue to mention there is no way you can do all these things without knowing why the patient was even in the hospital, and what has happened to the patient from beginning to today, and what information are there in the fact, and what information the patient can provide, and what information the patient relatives can provide. These are all important, and by the time you miss any of those information, taking any decision is very difficult, and the decision could be wrong. I also think that's why in some of our platforms you realize somebody goes a story about a patient coming with this, you see 2-3 lines, and before you know it, people will start giving as diagnosis. People will start giving diagnosis without any history, without any lab investigation, with just 2 statements about a particular situation. Somebody will start giving drugs. Somebody will give diagnosis. You can start picking up prescription. In a lot of cases, you see prescription with only and start thinking this prescription drug. In a lot of cases, you don't, because you need information about the patient for you to know why and how the drug was prescribed. A lot of drugs can be prescribed, are contraindicated because of certain reasons. The patient must take the drugs. So when you just look at the book, this drug is quite indicated. Therefore, you cannot write. You could be in for a very terrible situation, one way or the other. Sometimes it could be less, because the issue of academic decision is beyond the book. It is not that the book, rather, the book is not you exactly what you are doing. The book has given you and situations, patient peculiarity, and there are situations where options are not there. Therefore, you choose the last option because every other option will not go. Therefore, in this case, we are choosing this by indication because every other option has more dangerous impact on the patient than the contraindication. Therefore, the question of risk-benefit ratio comes in. So without information, without knowing what the patient is going through, without knowing about the diagnosis and some information, there is no way you can do drug therapy treatment. And these are some of the management, like prophylactic administration growth factors. Majority of we don't have this, the growth are not usually available, and therefore, if you want to bring down myelosuppression, you have growth factors available. It is usually administered in order to bring down this one of the myelosuppression. Extravasation. This requires emergency treatment. It's a situation where when patients are being administered a venous chemotherapeutic agent, there is this thing we call extravasation. That is break of the blood vessels and sequestration of the drug into the surrounding tissue rather than into the blood vessel. So once that happens, the patient will begin to have some pain. Once a patient undergoing chemotherapeutic process tells you that he's experiencing pain and the pain is increasing, you expect extravasation. And I tell you, this is an emergency situation because it can lead to the crisis of the tissue around, depending where the blood vessels break, where the chemotherapeutic agents are. Remember, they are toxic agents. Therefore, they directly kill whatever organ they come around. Therefore, that's the result. So, hot or cold treatment and potential antidotes are the treatment, but usually in emergencies. Dermatological toxicities that the alopecia, the nail changes, hyperpigmentation, radiation sensitivities, food syndrome, dry skin, most of these toxicities are ethics, and they resolve when the drugs are discontinued at the end of it. And secondary malignancies, I told you about those cancers that can be caused. The risk of secondary malignancies should be considered in assessing the adverse effects and profile risk and benefit of specific therapy. So if you want to make a decision of choosing therapy for any patient, you must look at the risk of secondary malignancy. What is the possibility that this drug is going to cause so kind of malignancy? Sarcoma? Is it head and neck cancer? Which type of cancer? And how will that take for cancer to develop? So this is the situation of the patient. Do we look at the situation and the possibility of causing cancer? Yes. At the end of the day, choice has to be made. The choice will be made by way of either changing or by way of using it like that. When monitoring the appearance of that malignancy, that's the thing to do. Gastrointestinal is highly susceptible to gastrointestinal tract is highly susceptible to cytotoxic chemotherapy and toxicities, and can include nausea, vomiting, mucositis. I told you about our old GIT and most of the irritation of that to the GIT. In selecting an appropriate anti-emetic regimen, relevant factors in the emetogenic potential of the chemotherapy drugs prescribed, the putative mechanisms of inducing emesis, and the likely onset of vision of symptoms. Individual patient characteristics also be taken into consideration because we have numerous emetics that are used, especially the 5-HT3 and other classes of drugs that are used in management of this. So you look at what particular agent is causing nausea and vomiting, and what is the possible mechanism which this vomiting is coming. So therefore, you can easily decide which drug. That's why managing toxicity itself is a topic on itself. Drug therapy remains the cornerstone of effective pain management, and this is where a lot of technicians fail, because the way we do pain management in cancer, we do it like in every other situation. We look at the pain we start from the bottom, and it is always wrong, especially in cancer patients. We have to understand how to recommend pain control, especially in cancer patients. Always start from the top down. That is the guideline. There are guidelines for the management pain in cancer patients. This is a topic for another day. Monitoring. I have spoke about monitoring at different stages. I told you about diagnosis from the beginning, and I told you repeating all that you have done during the diagnosis after the moment. That management could be either surgery alone, surgery and radiation, surgery and chemotherapy, or chemotherapy alone, chemotherapy and radiation alone, depending on, remember, we have two types of cancer. It could be liquid, solid tumors. It could be malignancy such as linear. It's not solid. So there are cancers that don't even need surgery because they are not solid tumors. So in that case, we talk about chemotherapy and radiation. So depending on which one, monitoring is important. And this monitoring, like I said in the previous lecture, it is either to monitor, it is monitoring both toxicity and response, is positive response. Monitoring toxicity because response, if you want to know how effective drugs are, you need to monitor both the appearance of toxicity and the reduction and elimination of drugs, and put together for you to know how effective your drugs or your management strategy is all about. So this is very important. I gave you an example of cervical cancer with discharge, coming with blood, coming with pain. That is just one aspect. We are talking about progression-free survival. We are talking about overall survival because the outcome measures, we have short-term outcome measures and we have long-term outcome measures. There are outcome measures, you can only use them probably during research. But the truth of that is you can use overall survival, you can use progression-free survival. For the progression-free survival is when a patient comes today and treatment is initiated today, we have all the parameters, lab investigation, diagnostic.
I can no longer hear anything. I don't know if it's from the.
I think it's from the presenter.
Yeah. Okay. Yeah. Okay. I think so.
Yeah.
Yeah. Both the audio and the video, I think,
the video
disappeared. So
Yes.
Okay,
I'm
so
sure it's
while
from
we are
him. Probably he's having an issue with his network.
Exactly. So while we are waiting for our conversation so that we can manage our time, I think we can start typing them in. While we are waiting for him, we have others who want to contribute so that we can just cover the time while we're waiting for him. I think it's almost done with the presentation. You agree with me? It has really been a great time.
A very wonderful one. Yes.
Yeah. So if you have other people that have experiences you want to share? Please, can we just start
I think
on
most of the participants are still muted, so they may have to be unmuted for them to fully participate.
I have some technical issues, but
Okay, he's back.
I'm back.
All right, okay, welcome back.
I cannot share the slide. We are almost done.
The slides.
The slide is I have to be made the host again because it's back to. I have been disabled from hearing the slide.
Please, Dr. Osman, you can just go ahead. Dr.
Okay.
Bello is not around to make you the host.
Okay, no problem. Let me just conclude. There's almost the last slide. So what's saying in essence is that monitoring anti-cancer therapy, the response to treatment is assessed by evaluating the therapy's anti-tumor and toxic effects and its effect on the patient's quality of life. Evaluation should occur at scheduled intervals and should include a physical examination laboratory tests, repeat diagnostic tests, and staging of the cancer. The toxicity also resulting from treatment is routinely assessed following each cycle of chemotherapy and may result in therapy being modified on subsequent cycles. For example, a dose reduction, a delay in treatment, or in some cases, looking for alternative therapy. So these are all very important. There is no way you can make any inputs if at the end of the day, one does not have all the information at hand. And the beginning where we have the diagnosis, the staging, the performance status, and the prognostic factors are the objective factors that you can use in an informed decision in terms of trying to know the effectiveness of your treatment. And part of the effectiveness of every cancer therapy or any other disease condition is being able to minimize toxicity. And by the time you are able to, because toxicities are very important, because in a lot of cases, toxicities tend to discourage patients from even continuing with the management entirely. So when those toxicities are not properly managed, when those toxicities are not properly minimized, you expect that in a lot of the cases, there is always tendency for the patient to either withdraw or to run away from the treatment. So managing toxicity is part and parcel of outcomes. And just like I told you, every single thing, right from the time the patient comes into the hospital to the end of when the patient is going to be discharged, regardless of the prognosis, the pharmacist has to be there and the pharmacist has to contribute as much as possible. There is no way anyone can assume, because he's a pharmacist, there is one kind of role you play that's just like what we call an event. You just come and say, oh, my role is just to sit down, somehow, in most cases where what we do, especially when we are making presentation, we just produce one slide, write a number of things, and assume these are the roles of the pharmacist. So the pharmacist is always at the cubicle, waiting for laboratory investigations to finish, waiting for diagnosis and everything. Then they will now come to your cubicle or come to where you are, and you begin to now play your role at the end of the day. The pharmacist's role is not at the end of every treatment. The pharmacist's role starts from the beginning of treatment to the end of treatment. Is to tell you, the pharmacist must understand every single point in the management process of any patient. The pharmacist must understand every single decision. The pharmacist must understand every single reason a particular decision is. That is the only way you can now see from here that drugs are usually not given alone. And the reason why drugs are given in combination is to have the combined effect of all the management processes. So why do you think you can just stay at drugs? Of course, stay at drugs and manage the drugs, but you must understand the implications of other places because they have implications on the drugs. So really, in conclusion, I have a few tips I've read as my conclusion. What I'm saying here is the roles of clinical pharmacists in the management of that patient largely depends on the understanding not only of the anti-pneumatic agent, but the disease and individual patient differences. Supportive care such as nutritional support, pain management, infection and nausea and vomiting require application of clinical, pharmacological, and economic principles. Provision of drug information to other healthcare professionals and to patients and their families is another critical role. Therefore, experienced and competent clinical pharmacists should take up these roles in order to make valuable contributions to patient care in oncology settings. This is the end of my lecture. Thank you for listening.
Nuruddin, you have really proud of this evening. I am particularly excited. It has been a very robust presentation and a lot of comments in the box as you are presenting. In fact, you just was to the class and at the same time we're having our internship in the hospital. It's really been experience and knowledge together. Because of our questions, I can see somebody raising his hand. Hassan Abdusalam Mohammed. Please, can you unmute yourself and let's have your question?
Hello.
Yes, you can go on.
Oh yeah. Nuruddin, you really did very well. You did justice to
Thank you very much.
pharmacists taking care of cancer. I have my concern as related to our role of cancer. I have a case study of a patient that has a issue of diagnosis in cancer management. Issue of diagnosis. The patient was, after the test that was carried out, it was found out that the histological test said that the patient has rhabdomyosarcoma. Rhabdomyosarcoma. Are you hearing me?
After testing, it's like the audio is not.
After the histological test,
Yes.
the patient was confirmed to have rhabdomyosarcoma.
Yes.
Which, of course, it was at an ABUTH, and I insisted. I said, well, if it is rhabdomyosarcoma, it was a growth that was just at the clavicle, at the left clavicle. If there was a mild growth on that side, and the surgeon, like you have already said, that treatment of cancer is either it comes surgically, that is local, or it comes with radioactive treatment, radiotherapy, or it could be systemic, which is going to be chemotherapy, right?
Yes.
Yes. But surgical, I'm now talking about the issue of the surgical. The surgical, when you wanted to operate cancerous, not encourages spreading of the cancer cells. If you want
This
to
last statement. Come again. This last part.
if you choose in a situation where surgical therapy is indicated for cancer treatment, you need not encourage the state of the cells, cancerous cells,
Seriously, the audio is not helping. I cannot get this last part where you are even asking the question.
No, can you hear me very well?
Thank you very much.
Amaka, please,
Something is wrong with this audio. It's like
if you actually,
You can write it. You can write it now. You can chat it up.
please, just type it and we can read.
something is wrong with this audio.
The audio is not very clear. Okay, so maybe while we're waiting for him, there's a question already in the chat box,
Okay.
and I'll quickly read. Are you here very well?
Okay.
All right. Said, what is the significance of bone marrow markers, biomarkers in choosing patients who will benefit from chemotherapy or other?
From other.
What is the significance of biomarkers in choosing patients who will benefit from chemotherapy or other lines of procedures?
Who will benefit from chemotherapy and
or other management procedures apart from chemotherapy?
I understand. As you can see, biomarkers, as the name implies, they are monitoring parameters. And as I said in my, and I've said severally in my lectures, biomarkers are used as diagnostic parameters and at the same time as for monitoring parameters. So the choice of treatment is not based on biomarkers. Rather, biomarkers are used to make, in fact, sometimes they can use biomarkers even without cancer to assess the risk of cancer. For example, I gave example of PSA, prostate-specific antigen, is a biomarker for prostate cancer. You could have a high level of prostate-specific antigen without having prostate cancer. But the more the prostate-specific antigen goes up, the more likely you come down with prostate cancer. However, if one is diagnosed with cancer, prostate cancer, that means if the cancer exists in real sense. Now, the role of prostate-specific cancer now is to determine the extent of the severity, that is the level, after doing all the staging and everything. That marker is just one out of other parameters that can be used to monitor progress or otherwise. So when that patient is under treatment, from time to time, after every 3 weeks, 4 weeks, or 5 months, depending on the case may be, that prostate-specific antigen will be measured and tested. Then you now compare with the initial measurements when the patient was diagnosed. Ordinarily, it should go down. In prostate, in cervical cancer, there's something they call CA125. This is a marker for cervical cancer. So patient can be assessed for that particular marker to know whether they have risk for development of cervical cancer, or at the time they are diagnosed with cervical cancer, is one of the markers that can be used in monitoring to understand the prognosis. That is how good in terms of outcome is also biomarker. So all those biomarkers are monitoring parameters. Of course, at the time of diagnosis, they are very important. Now, when you are taking decision about choice of management between the options available, you look at all the factors I told you. This is the diagnosis. That diagnosis, part of the reasons it was diagnosed is those markers present. So after the diagnosis, the staging, identifying the status of the patient, looking at all the prognostic factors, and as decision is made and the goal of therapy is also formulated, has also been established, then you now go into treatment. The choice has been made, clinical decision has been made. Now, at the end of the day, you now move It is either you continue to monitor those markers when treatment is ongoing after some time to see the level of impact and effectiveness of the treatment. And at the end of the treatment, even after the patient gets well, you also measure those markers, depending on if your goal is to cure or your goal is to bring down the symptoms to a manageable level in order to improve patient quality of life or to a little bit increase lifespan, depending on goal. That is why that goal is very important. There is no way you can choose any management without establishing the goal of managing patients. So markers are markers, and they can be used either way: diagnosis, monitoring therapy, and assessment of risk. In fact, they can even be used to assess the risk of having cancer, even if you are not a cancer patient. That is markers. I think there's another hand.
Yes, there's another hand up there. From
Aminu,
Ahmed Aminu Biambo. Please, you have the floor.
unmute yourself.
You can unmute yourself.
Hello.
Yes.
Okay. Good evening.
Go ahead.
Thank you, CPAN Oncology Group. Thank you, the presenter and the moderator. And all of you, thank you for the wonderful job. It gives me great pleasure to participate, I think not proudly, for the first time in this wonderful group. The presentation is rich, but since we are discussing the general modality for cancer management, we will expect that there are too many people probably the most thing to take, because that is why it is, because that is how it is. If we look at cancer management generally from clinical pharmacist point of view, we'll see that an expert in one cancer will probably need some little more mentorship or training to also be an expert in another cancer aspect. And I believe in the coming weeks or months in our presentation, we're going to focus on specific cancers with practical information, cases, scenarios, and what have you. And that is when I believe we will begin to concentrate on the things we will be more interested in, like the things that has to do with innovation of clinical pharmacists with specialty in oncology. And we will de-emphasize some theoretical aspects. This presentation has given us a lot of road to the practical aspect, the chemotherapy aspect, the targeted therapy aspect, the monitoring parameters, and a lot of things. And this is just more of my contribution as a member of this honorable branch of CPAN. And I believe when we refocus into specifics, we're going to have a lot about it. And I also look forward to us meeting in the forthcoming conference. Hopefully after CPAN AGM, we are going to have our little get-together, collaborations, and a lot of things. Finally, cancer generally is an aspect that has a lot of global interest from every aspect, either economic or the public health interest, because of the difficulty in the management and the poor prognosis that are there. So whenever somebody has anything little, anything good to contribute to cancer management, then he will have a lot of audience and a lot of subscribers to that, especially in the developed world that has more of that burden of this disease. The developing world is sharing more of the burden nowadays because of our poor management aspect. And this is a big opportunity for clinical pharmacists. There are medicines there are modalities, there are guidelines, but the management is what contributes largely to poor outcome. So you manage largely with medicines. So isn't that where a clinical pharmacist will explore all his potential and have his own target, then make it an outcome-oriented kind of practice, so that we will have both the recognition, the financial and economic gain, and also the public health impact that we strive to do. I think shortly, this is my little contribution. Thank you very much. Have a wonderful night. Bye-bye.
Thank you very much. Thank you very much, Dr. Aminu Diembo. I think there is a question on the chat box saying, even though you said much about treatment of cancer with conventional chemotherapy and natural herbal treatments, based on side effects of chemotherapy, I think as pharmacists, we need to do more to encourage and promote herbal treatment with low adverse effects. This is true. Nobody will discourage development of herbal medicines. But what we are saying here is we cannot continue to claim herbal medicines without evidence. The only way herbal medicines can work is when we are able to integrate the two. A herbal practitioner cannot just begin to manage a breast cancer patient without understanding those markers and those biomarkers that he can monitor to be able to know whether your herbal drug is working or is not working, whether the side effects is less than the conventional ones or it is not less than the conventional ones. What we used to have at the end of the day is someone placing a particular patient on herbal medication for a number of months or a number of years. And at the end of the day, the patient will come down to the hospital after the cancer has traveled to distant places. So in most cases, they tend to muddle up the waters. They tend to complicate the matters and take the patient to their early grave. So a lot of cancer herbal drugs have potentials of becoming anti-cancer, of being considered as cancer therapy. But you cannot risk the life of patients with that. Of course, I told you at the beginning of my presentation that those traditional bone setters are have begun to get themselves aligned with the modern practice, whereby they send patients to radiographic investigations to look at the bone, and after the setting back of the bone and monitoring the process, they send back to identify, because they realize over time that they have caused a lot of people lose their limbs, either the hands or as a result of poor bone setting process without monitoring. So we cannot continue to afford that. Part of the reason we have a lot of cases, especially in Africa, especially in Nigeria, is because of this type of belief, religious beliefs, and some people that used to confuse other people about that, the fact that cancer doesn't like hospital. Immediately you come with any kind of growth, they begin to tell you, don't go to hospital, don't go. And you only get to hospital when it has gone advanced. And by the time you get to advance, I told you, 3 goals. If it is not cure, it is purely palliative. If it is not palliative, it's just to increase your time a little. And I assure you, majority of the patients that come down to teaching hospitals, they have already finished using all the herbals. And after it has gone to the last stage, they come to the hospital. And when they die there, their relatives will say they killed them in the hospital. And the next thing, they will start telling people that this guy went to the hospital and was killed after they killed him at home. And that is exactly how we manage. So, of course, we continue to explore. Researches are ongoing, and we continue to do those researches. And we continue to encourage traditionalists to continue to come up with medicinal plants that have potentials to become to be used for cancer management. But we must understand this process so that we can align, just like the traditional bone setters are trying to align. They are not yet there too, but this is the only way to go. Thank you.
I think from Nura, I think,
Yes.
hello?
Yes, I
From
can hear
Nura,
you.
we the pharmacists, we're supposed to be the interface between the traditional healers, because we are working in pharmacognosy.
Yes.
And pharmacognosy is all about natural products. And we have vinblastine and vincristine that are Vika alkaloids that
Yeah,
have been
yes.
proven.
And they are already incorporated into the orthodox.
Yes. So this is exactly what I'm trying to say, and I'm trying to point out about we trying as much as we can to now marry our pharmacognosy through making sure that
yes,
this product, and
yes,
we take lead. We don't leave this herbal people. There's no people like herbal. We are the herbal. We are the herbal. We the pharmacists are the pharmacognosy. We know we have the scientific base in order for us to be able to standardize this product, in order to use it clinically, in order to address this cancer situation.
In fact, that's one of the challenges we have in pharmacy. In fact, a lot of our pharmacists don't even want to go to pharmacognosy because they feel they want to become herbalists. And right now we have, especially in the northern parts of Nigeria, we have scarcity of pharmacists as pharmacognostics. So with the moment you talk about herbalists or traditionalists, people don't even think about pharmacists because we are trying to think from another direction. But what you are saying is very, very correct. And that is what we should do. And pharmacists are in a better position to do that. As a pharmacist, when I know I have a plant extract that has potential to be toxic on cancer cells, and it is safe based on all the laboratory parameters in pharmacological testing, I know I can safely use it on a patient and continue to monitor the patient based on those parameters. And from there, we can only improve. Because with the knowledge of anatomy, physiology, biochemistry, a lot of things can happen. And in fact, it's just that in Nigeria, we have a lot of issues. And a lot of people disguise to use that opportunity in making money. And that is what is killing the profession. That's why some of us don't want to identify ourselves as traditionalists. But definitely we are the traditionalists, because most of what we do, the origins is from pharmacognosy. It is very, very true. So I think we are done.
Yeah, we are very happy with the presentation this evening. It's so educative.
Thank you very much.
Everywhere.
Thank you very much.
We appreciate you. Thank you very much.
Thank you very much. The moderator.
Yeah, thank you very much, everyone, for your attention and contribution. As we round up this night, I just want to highlight some of the salient points. From has taken us through the diagnosis, the staging, and all that we need to do. The conclusion of the presentation is that pharmacists are needed right from the point of diagnosis, right through the point of management and treatment, pharmaceutical care and clinical. But I just want to add, from the presentation, we are saying that early diagnosis is very, very important. So I think this is a very, very crucial point wherein they can bring in our intervention. I'm a public health pharmacist, and I think prevention is actually the best all the way, especially in cancer. In the past 2 or 3 weeks, I lost 2 of my close friends to cancer, and it's a major one. And I'm telling you, I feel so bad because of negligence. But the 2 of them just came out very late, just to protest what the presenter said. I cannot imagine that, somebody is scared of even going to the hospital. The doctors were calling one of them that come to the hospital. But of course, by the time he was coming out, it was too late. It was too late, and there was nothing anybody could really. And that is what we are saying. So what is coming to my mind is it possible for all pharmacists in one corner of our community practice in the hospital, we just have an IEC material, information, education, areas, telling people about early diagnosis of these cancers. And when you see the sign, the next thing to do. In the area of pharmacognosy that we're talking about, it's starting to know that right there in pharmacists, there are so many researches that has not been published, and they are just lying there on the shelf. What are we going to do? We need to call on our colleagues in the academic, start publishing some of this work so that we can really go all the long goals. I know I am the pharmacist, I'm happy to be one. My grandmother happened to be an herbalist, and I know that there are still the new plants. Even as I speak to you today, I still give somebody a particular herb to manage anemia because I know that it has been working. I have it at home. And there is need to, because I also manage a sickle cell group, and I know that it works very well. My grandmother used it, I'm using it, and I know it works. Okay, and there is research on it. So what I'm saying at this point is, I think we're getting to a point where pharmacists really need to, explore all that we have learned from school, even at this point in time in our practice. I want to thank everyone for listening. I want to thank our presenter. In fact, I don't feel like it should go on and on as I was just. So thank you so much for your time, for sharing your experiences. For those that have asked questions, thank you for staying all the way. Dr. Rita, you've done really well, and everyone. I've seen some of my senior colleagues here on the platform, and some others that I don't know, and all that I don't want to start mentioning.
CPAM president is there.
Yeah, CPAM president and all the PSN members. I see some of my PSN fellows too from Ogun State, and my one and only mentor. In fact, I've been able to make this meeting. We were meeting together, and I got up at the pharmacy house. He had to stay with me also to ensure that my car moved. I just rushed home to join the meeting. I want to say thank you for helping me to make me miss this meeting today. And like the penultimate speaker spoke on the issue of how going into cancer, I think is a very welcome idea. And I would like to encourage Dr. Rita and all the organizers. Let's start working on it. I keep asking, who's the first? Who trained the first? Who did the first one? Yes. We're actually doing good work, and I'm sure that one day we'll get there. Thank you very much for your time, everyone, and I hope we'll meet soonest again. Thank you very much. Dr. Rita, please over to you. Can you just close the meeting so that we can go to bed or continue our other business?
Thank you, everyone, for participating in today's clinical meeting. We appreciate our guest speaker and our moderator. And I think we have a lovely night rest. Thank you all for joining us.
Thank you very much.
Good night.
Thank you, and good night, everybody.
Good night.
Good
Good night, Doctor. Bye-bye.
Good night.